Welcome to today's webinar. This webinar is titled A Heating Climate, Extreme Water Events and Health Outcomes Among Vulnerable Populations. I'm very pleased to introduce the webinar today. It's sponsored in the Office of Global and Community Engagement in the Office of the Provost at Loyola University, Chicago. And we're also pleased to have this event and this webinar be one of our signature events for International Education Week, which is happening during this week at Loyola Chicago and all across the United States. My name is Father Scott Hendrickson, and I'm Associate Provost for Global and Community Engagement here at Loyola Chicago. I'd like to welcome you again to this event, which is part of the Forum on Global Affairs, specifically water insecurity across borders. And this is the second of two talks during this semester. We will have two more webinars in the spring semester as well. And so I'm pleased to introduce our moderator of today's event, Dr. Laura Dugas, who is joining us today from a research site in Ghana. Dr. Dugas is the AXA Chair in Non-Communicable Disease in Epidemiology, hosted at the University of Cape Town. And she is Associate Professor of Epidemiology in the Department of Public Health Sciences at Parkinson School of Health Sciences and Public Health at Loyola University, Chicago. She joined Loyola in 2007 and has managed a large international study exploring the effects of diet and physical activity in 5 African origin populations from Ghana, South Africa, to Jamaica, the Seychelles, and in the US. And since then, her research projects have grown and expanded, and we're very pleased to have her join us today. So now I turn it over to Dr. Dugas.
Thank you, Father Scott. It is my great pleasure to welcome you all to our webinar, and it is titled, I'm going to be starting to, actually, I won't share my screen. I'm going to go straight to the talks because we've got so much to tell you about. The topic of climate change, extreme water events, and human health is it has gained so much in the last decade, and we're certainly at a point where even if we were to mitigate the increasing temperatures, the impact on vulnerable populations is going to be felt around the world. Our research, a lot of our research focuses on populations in sub-Saharan Africa, where the impact of these extreme events will be felt most among those that are most vulnerable. 50% of the people who live in sub-Saharan Africa are living in rural and rural communities. So this massive problem calls for interdisciplinary work, and I'm really excited today to present 3 scientists who work in 3 different fields. Interdisciplinary work will need to come from climate scientists, health scientists, including anthropologists like Dr. Amber Abrams. On our panel today, though, is Dr. Julian Sanchez-Perez, and she is an endocrinologist at the University of Illinois in Chicago, and she will be talking about her work looking at the missing research from climate change and type 2 diabetes. Then next up, we'll have Dr. Amber Abrams, and she's a medical anthropologist from the University of Cape Town, and she has been examining extreme water events and human health. And then we're going to wrap up with some real research on the ground, and that is going to be by Alice Gwynn Evans. And she recently completed her honors program in environmental and geographical sciences at the University of Cape Town. And so she'll be sharing with us some data and how we can use human and climate science together to come up with solutions as we understand the real depth of this problem. So with no further ado, I'd like to welcome Dr. Julian Sanchez-Perez. So Julian is originally from Puerto Rico. She obtained her bachelor's with honors in industrial microbiology at the University of Puerto Rico in Mayos, Puerto Rico, and her MD at the Universidad Central de Caribe in the Baymont in Puerto Rico. She has both laboratory-based experience as an undergraduate student at the University of Puerto Rico and as a research fellow at the Cincinnati Children's Hospital. In medical school, she participated in an NIDDK-sponsored summer medical student program at Vanderbilt University, where she worked in clinical studies examining the effects of diets and insulin in patients with obesity and type 2 diabetes. And after completing her internal medicine residency training, she will be staying on at UIC to pursue an endocrinology fellowship at UIC. She was also recently awarded an NIDDK T32 Diversity Supplement Research Grant. And it is my great pleasure to introduce Julianne and her work that she's been doing looking at climate change and type 2 diabetes.
Thank you. Good morning and good afternoon, depending on where you're joining us from around the world. I'm Julianne. Thank you for your introduction, Lara. And I will start sharing my screen and get us started. Okay. Everyone should be now seeing my slides. So today I will be discussing, like Lara mentioned, the impact of climate change on diabetes. And before I officially begin, I wanna give thanks to the organizing committee and for the invitation to participate today and share my research. Here. So I'm starting my presentation showing the amazing team that I had that was helpful to me and guided me so that I could actually complete what I'm about to share. My attending at UIC, Dr. Robert Sargis, he recruited me for this study. And between him and our amazing librarian, Holly Hudson, they were essentially the core so that we could actually get this project moving and completed. I also had the assistance of my endocrinology fellows and some internal medicine residents and medical students. And we had our senior faculty experts, where actually Dr. Lara Dugas was part of, along with Dr. Tandy Kapwara, Amy Luke, and Dr. Amada Graf Aikins. And one of the things that we wanted when we put together the group that was going to help us with this project was to get a very cultural diverse group, and we were able to successfully do that. We had people representative of US, India, Jordan, Egypt, Ghana, Puerto Rico, South Africa, and with very diverse backgrounds as well. So for our project, what we did is we used 3 different databases. And what we were doing was a scoping review. So with a scoping review, we were specifically focusing on what are the gaps on the current known data out there so that we could identify where should future research focus and move towards. So we used 3 different databases, Embase, PubMed, and Web of Science, and we also did a hand search through the Journal of Climate Change and Health. We limited our search to the last 5.5 years, so from the start of 2018 up until July 2023, which is when we downloaded the different articles from the different databases. We crossed climate change terms and diabetes-related terms. And the climate change terms that we used were extremes for temperatures, so extreme heat and extreme cold, and also natural disasters. Looking more deeply into our inclusion criteria, for diabetes, we specifically included type 1, type 2, gestational, and pediatric diabetes. So we were very broad with all of the diabetes that we included. We included great literature and primary source peer-reviewed articles, and only human studies. For our exclusion criteria, we excluded plant and animal studies, review articles, the articles that focus more on pollution rather than climate change, and we also excluded for earthquake-related articles because earthquakes do not increase in frequency due to climate change. Therefore, tsunamis were also excluded from this specific review. So we identified around 2,800 articles at first, around 800 of these were duplicates. So we actually started our screening process with 1,991 articles, so almost 2,000. And we did the full, the title and abstract review process, and each part of our review process was done by two different persons, two different reviewers, in order to help eliminate biases. Upon finishing the first part of the review, we then proceeded to the full article review, and we started that part with 158 articles, and we were able to reduce that to 73. So at the end, 73 articles actually made it into our review. So we put this table together to help us categorize each article based on the topic discussed on the article. If you actually sum and add up all of these numbers, we end up with more than 73, which is the amount of articles that we included. And the reason it's because there are some articles that actually discuss more than just one topic out of the ones that we put in our table. We would select which type of diabetes was being discussed in the article, and also what type of climate change event were they discussing, whether it was heat, cold related, or related to a natural disaster, and then what specifically related to their diabetes was being assessed. In this table, when we originally created it, we also had a column at the end for childhood diabetes as a category, but only one article fell under this category. So for visual representation here today, I eliminated it from the table. And if we look closely, there's a big number under the others category, more so in the heat related one. So what other things were actually being assessed through these different articles? So heat related mortality was also assessed, and actually mortality was assessed under associated to heat, cold, and natural disasters. The reason why I specifically put mortality in the others group, it's because the articles the majority of them did not specify the reason behind the mortality and the cause of death. So I wasn't able to assess whether it was a death associated to diabetes or if it was secondary to another condition. Other things that were also assessed was the amount of ED visit, healthcare utilization, and different biomarkers, some pro and some anti-inflammatories were being measured to know whether the concentrations were changing after exposure to heat. Hospital admissions, urinary metabolomics were other things that were assessed, specifically related to cold exposure. And related to natural disasters, they also looked at amount of hospital admissions and emergency room visits, prescription field patterns, healthcare utilizations, urinary metabolites, and psychological and social determinants. So now going again into the table that we put together, in this table, in this slide specifically, and I am highlighting in light blue the areas where we did not identify any articles published. And basically what we learned is that there's key data gaps related to diabetes associated complications. We did not find this assessed in any articles, regardless of what climate change event was being explored with the articles. We also did not find enough any non-glycemic metabolomic outcomes. Only one identified childhood diabetes article, so this was also identified as another data gap. Gestational diabetes, we found that it was explored and studied much less compared to the other diabetes. And I think one reason why that can be, it's just because gestational diabetes has a shorter time frame, so it's also more challenging to actually complete the studies, but it's another area that we identified as a gap. And one thing that we specifically did not look into with our study was the impact of climate change on nutrition. And I do realize, obviously, that diabetes and nutrition go hand in hand. So this is one thing that we were missing with our study. and one thing that we consider that is extremely important and should be looked into in the future. And we also noticed that the impact of extreme cold and natural disasters is underrepresented, specifically compared to heat-related studies. And we did not include any studies related to earthquakes, like I earlier mentioned, but despite it not being related to climate change, we still think that the data from those articles can still be helpful to know what to do with different disasters and how to proceed. So then what I did in this map in the top, I put the different countries where we identified that data was being published from. And I compared it with this graph from the NOAA, which this graph in the bottom, what it shows is the change in temperature in degrees Fahrenheit throughout the last 3 decades. And the hotter, the redder in the graph, then the hotter that specific region has gotten throughout the last 30 years. And what I was able to conclude and get out of this comparison is that there isn't adequate data being published from the areas in the world where there is more warming up and has been warming up the most throughout the last 30 years. Another way that I try to identify and interpret where is the current data from, I compared the articles that we have and the countries where the data is getting published from with the data from the International Diabetes Federation. The International Diabetes Federation, back in 2021, they released their 10th Diabetes Atlas, and that's where I got the table, the map on the left side of the screen from. If we look closely at this map, what it represents and what it shows to us is the increase in incidence of diabetes that is expected to happen from 2021 to 2045. And if we look at the areas of the world in the bottom of that map, we can see where is it expected for the increase in diabetes to happen the most. And those are the areas of South and Central America, Africa, Middle East and North Africa, and Southeast Asia. Now, on the graph, on the map on the right that I have here, what I did is that I put in orange the countries in the world where we were able to identify data being published from. And the red highlights that I have here are the top 10 areas in the world where the International Diabetes Federation expect the highest incidence in diabetes by 2045. And again, in this map, we can see that there isn't adequate overlap between the areas where we expect diabetes to worsen throughout the next coming years. So to summarize, based on the data that we have at this moment, we were able to definitely see that there's a link between climate change to various adverse diabetes-associated outcomes, such as altered glycemic control, hospitalizations, mortalities, and others. The current data is sparse in several key areas, like diabetes, associated complications, pediatric and gestational diabetes, and non-glycemic metabolomic impact. Lessons may be learned from other areas of disaster medicine, including earthquakes, and data is missing from the geographic regions with the greatest rise in temperature and most rapidly rising rates of diabetes. Therefore, further research should focus on geographic areas at greatest climate and diabetes risk, which are Africa, Middle East and North Africa, Southeast Asia, and South and Central Africa. And further work should also look at the impact of climate change in nutrition and diabetes-associated outcomes. And with that, I conclude my talk today.
Thank you so much, Julian. You really have set the scene very nicely for us to show that the data really support that the regions in the world that will be experience the greater impacts from climate change are also those that are the most vulnerable and those that have the least resources and the least documented research. And this really segues very nicely into the work that Dr. Amber Abrams does. So Amber really looks at not only climate climate change, but she also looks at extreme water events, including droughts and floods, and how these impact human health, with a focus on mental health. And so Amber, let me just first introduce her. I'm very excited about her talk, but she is a Carnegie Deal Junior Research Fellow at the Institute of Future Water, which is a transdisciplinary research institute at the University of Cape Town. She has been a postdoctoral fellow at Future Water since 2018 and a PhD research fellow candidate at the School of Anthropology and Conservation at the University of Canterbury in the UK, with research focused on well-being on the boundaries of protected natural areas in the northern Limpopo region from South Africa. So her training is really in medical and environmental anthropology and public health. And her work really spans numerous projects, including experimenting with different research methods around water. So her research in the past has used arts-based and embodied methods. She's looked at the development of a health vulnerability indicator framework for the context of extreme weather events in Southern Africa. She's also hosting an online museum of watery relations, engaged and interactive exhibitions to sensitize citizen scientists to their relations to watery flows in Cape Town, specifically attending to water as a human right and to our places in the Salt-to-Sea hydrosocial cycles, and engaged research on citizens involved in water-sensitive urban design interventions. So without further time, I want to introduce Amber. Amber, the floor is yours.
Thank you, Laura, for the introduction and for the opportunity to present here. And thank you to, I see some of my colleagues are online here. So just to say that what I'm going to present today was a big team event, and I will introduce some of those people as well. Okay. Screen sharing. Okay. So I'm going to talk to you a bit about our efforts towards creating a health vulnerability index, but focusing on extreme water events. And as Laura suggested, the work that was done was emanating from the Future Water Institute, which focuses on water resilient futures and addresses kind of diverse relations and values around water with the aim of incorporating water sensitive design, resource recovery from the circular economy, and integrated water resource management. My research team for this project was, we were mentored by Professor Carden and Professor Dalby, and the project was coordinated by MPH graduate Tahira Asmal. The rest of the team here listed, Dr. Stahlala as a postdoctoral fellow, and then a number of MPH students, Michaela Deglan and Letabu Mechoba, are both here, and both actually produced publications out of this work or related to this work. There's also a social anthropologist and master's student who worked on this project, and a number of other researchers from Future Water who provided time and input to this project, particularly screening, because as you'll see, we started with over 15,000 studies to review. So what I'm going to tell you a little bit about are two studies. One was a drought study that Tahira ran as her MPH project, but I supervised, and that focused on health impacts that can be directly linked through evidence, so studies, to drought. And the other was a Water Research Commission funded project looking at health vulnerability indicators, taking on the drought study lessons learned, but incorporating another review, a further systematic review, including extreme water events like flooding and also extreme temperatures. And I'll explain the trickiness of disaggregating those things in a moment. But we aimed to understand how these health risks or these environmental risks led to health outcomes. And so we did a kind of scoping, first a systematic review in the drought study, and then a scoping review to attend to the fact that we had to do it a little bit quicker with the other extreme weather events. And those include flooding, extreme heat, because like Julian, we didn't find anyone looking at extreme cold in our Southern African context, and fire and storms, but I'll explain that all in a minute. I'm gonna focus on these last three processes that we undertook in today's presentation. But just to say, we did a scoping review, we developed draft draft frameworks of these outcomes based on the outcome evidences, and then workshop them. So tested it in situ, and I'll explain that shortly as well. And then we refined our frameworks. So we broke down our extreme weather events into 4 categories. We drew on Earlham, who I see is here today's paper exploring the Southern African extreme weather events. And then we worked very closely, and UCT Health Sciences librarians cannot be thanked enough for their work in helping us make these search strategies correct and help us find exactly what we needed. And then we worked really hard on defining the weather variables for these extreme heat, wildfire, and flooding, so our exclusion-inclusion criteria. And I can talk to that later, but it actually is probably quite important to note that there's a lot of variety in how different people define what is an extreme heat event or what is a flooding event. Here's some indication of the searches that we ran, just to give you an idea. So we worked with PubMed, Web of Science, Africa-Wide, and Scopus. And here's one of those nice flow diagrams, just like Julian was showing you guys, but here's our drought one. And you can refer to this if you want, it's in the Science of Total Environment, but ultimately for the drought study, we started with 2,000 records and we ended up at 15. Here's the prism of flows for both droughts. So drought, you can see we started at nearly 2,000, ended up at 15. And then because of the difficulty of disaggregating what was identified as heat, flood, and storm events, we lumped them together because we found a lot of studies reported on multiple ones, also because we needed to do the scoping review really quickly. And we started with 15,000 studies, but once we lumped them together, we deduplicated and we were down to 11,421 studies. But in the end, what's important is we ended up with 75 studies. We also, importantly, we understand water to be linked to wildfire. We did search for wildfire studies, but we found none that were actually relevant when our inclusion criteria was kind of refined. And so we had 90 included studies between the different EWEs we were exploring. Here's a really small, difficult way of seeing what I'm going to show you in a second, which is our findings from the drought study showed that we could categorize the outcomes, the evidence-based health outcomes, into 3 different categories. So adverse nutritional health, disease due to microbial contaminations of water, and health behaviors. And what we found were malnutrition, wasting, stunting, or underweight, mortality, which again, like Julian pointed out, is a really tricky category because it's always difficult to categorize the actual mortality event and its connection to what you're looking for. Anemia and disability. And then within the microbial contamination of water, we noted cholera studies, diarrheal studies, scabies outbreak studies, vector-borne disease outbreak studies, and malaria-related studies. And the health behaviors indicates that the HIV prevention cascade was interrupted during drought as well. So the factors that make people more vulnerable during drought are your age, so if you're a child, your characteristics, because that we found was a nutritional challenge, maternal presence and education, low adaptive capacity, so including the financial status of a household, reduced availability of safe drinking water, contextual factors like local disease burdens, but also kind of microbial loads, and existing political tensions. We had some limitations and challenges in the drought study, and we learned some lessons for our next reviews. But basically, one key thing is that it's very difficult to ascertain onset and duration of droughts in a kind of concise and decisive way, and there were often confounding factors. So it's very challenging to do these types of epi-environmental data extractions because of the variability in way things get defined. But we were lucky enough to be able to, with the pushing of Tahira, get this published. And so you can find more information, but please feel free to reach out to me. But what we did learn for the next phase was that rather a systematic process, but a scoping review would be more effective for what we needed. And so that allowed us to also move a little bit more quickly and refine our inclusion criteria better. So this shows you what we found in flood studies, or actually the flood studies themselves. And here we can see that fancy table all summarized as well. So there we noted an increase of disease occurrence, including diarrhea, cholera, malaria, typhoid, hepatitis, scabies, and Rift Valley fever, an increase in intimate partner violence, an increase in hospital admissions and mortality, including all-cause mortality and flood-related mortality, mental health effects, including stress, anxiety, PTSD, disrupted sleep, chronic kidney disease, and negative maternal and neonatal outcomes, including wasting, undernutrition, and stunting. So the factors that are indicators of vulnerability for drought are very similar, but there are some different ones. So here it's damage to assets, lack of proper drainage systems, dams, infrastructures, and waste removal, individual factors such as age, gender, marital status, and physical ability. And then reduced availability of safe drinking water, contextual factors, including your housing structure type and location, and then a lack of recovery systems for those who are displaced, particularly those who are challenged with socioeconomic status. So what we did next was take all of these outcomes and work backwards to find pathways to what might make people vulnerable with these outcomes. So that's how we told you those vulnerabilities. We did 2 to 3 workshops per week over a course of about 6 weeks on each of the outcomes or each of the study subsections. And we created a framework that we then tested. Here's an example of what one of the frameworks looks like. Here's some, zoomed in aspects of it. So you can see that we looked at exposure, we looked at sensitivity, and we looked at local capacity to adapt or respond. But what became really important were our engaged processes to see how these frameworks spoke to people's lived realities. So here we're working in a neighborhood where they just experienced a flood. We brought through our frameworks and we said, well, what have you learned from your flooding experience that's not on our frameworks? And very interesting things came out. We don't necessarily have the evidence to support that, chest colds emerge from standing water, but we're looking to find these connections and understand what people's experiences are about. It's important to say that this was all done during COVID. You can see we're wearing masks. And this was only done once we were allowed to go back into the field, which is about a year after we'd done the kind of data extraction. And so our workshops were really, really valuable, but we didn't get to do enough of them before the project closed. And so what I'd suggest is that these frameworks are useful tools, but they definitely need to be continued to engaged with. And the engagement part is where you learn the most. You learn the most from local residents who've lived through these experiences. One of the things that we also would like to raise is that there's, like Julian did, there's limitations for this type of research and for the existing evidence-based. So there needs to be more specific focus on extreme weather events. For example, wildfires had no data, but then also disaggregating temperature events from water events to understand these a little bit better. And then understanding the overlapping of these extreme weather events in systematic ways so that the studies can show maybe what the causality between a particular drought followed by heavy rains and the relations therein. But we know how hard those can be. Here's a lot of kind of recs. I know I'm running out of time. I imagine I'm running out of time at this point. But what I think is really important is that these indicators build on other indicators. And so there are already kind of climate risk vulnerability assessments, and they should be used in line or alongside these other more detailed and nuanced health specific ones. I've already mentioned all of these things, I think, here for future research, but I think engaged research on a larger scale is really important. I'd like to note that coordination of extreme weather events with early warning systems is possible, and I know that South Africa is working on it, so I think it'll be a great opportunity for cities to then circulate specific disaster risk management guidelines as they know something is happening. And that water-sensitive design, which we do at Future Water, and I'll talk about in a second, addresses both drought and flooding. And we'd always like people to think of WASH, water access, sanitation, and hygiene with the D at the end, drainage as well. So Future Water, as I said, is a transdisciplinary research institute, and we really are looking for opportunities to demonstrate how water-sensitive design could improve water quality, and how we can rethink governance and skills capacity around kind of things like challenges between droughts and floods and other water-related events. So we are working towards that through a project called RRIP. And here is the fancy acronym. It's Reorienting Research, Innovation, and Practice to Address Future Water Challenges in Africa. And we aim to kind of shift everyone's thinking to be a little bit more holistic about their relations with water. And it's not letting me move on to the next slide for some reason. Which is probably my last slide. So let me see if I can make that happen. Apologies, everyone. How embarrassing. Okay.
All right. Oh, there you go. You got it.
There we go. Just to say there's other related research, and thank you for this opportunity. We would love to hear from anyone who's interested.
Thank you so much, Amber. It's always such a treat to listen to you and the incredible work that you've been doing. And this, we started out with Julian's talk, really getting a picture of where the gaps are in the literature, and you've really drilled into now water-related events and actual studies. And our last speaker is going to be Alice, and Alice is going to be presenting data from actually one of my studies, and where we actually can start to fill in some of the missing gaps in the literature. And so it gives me great pleasure to introduce Alice. She has recently obtained her honors in environmental and geographical sciences at the University of Cape Town. And she has a very full and wide background in human genetics, anatomy, physiology, and of course, environmental and geographical sciences. Her research really focuses on the intersection between health and environmental conditions, and she has a profound passion for social and environmental issues. She has really effectively channeled her expertise and enthusiasm to drive positive change. And so it gives me great pleasure to introduce Alice as she presents her thesis looking at how increasing nighttime temperatures reduce healthy sleep in a low-income settlement. All yours, Alice.
Thanks, Laura. I'm just going to share my screen. Right, there we go. Great, thank you for the very kind introduction, Laura. So, as we all know, climate change and global warming at the current rate is a huge problem we are facing globally. Romanello et al. Predict a 2.4 degrees Celsius or 36 degree Fahrenheit increase in average global temperature by the year 2100. And while the negative impacts of climate change on health have been fairly well studied, there is not much research on the effect of rising temperature on sleep. And as identified by Julian earlier, research gaps are largely prevalent in the global south. Additionally, low-income settings are especially vulnerable to heat stresses and are thus an important aspect when looking at the impacts of global warming. So today I will be exploring how increasing nighttime temperatures reduce sleep in low-income settings, and a focus on Khayelitsha, which is a township in South Africa. So sleep is important for a number of reasons, including cognitive function, performance and productivity, physical and mental health, hormonal regulation, and very notably, insufficient and poor quality sleep contribute to and exacerbate cardiometabolic disease risk. Inadequate sleep can lead to the elevation of blood pressure, increasing the risk of hypertension, as well as increasing the likelihood of obesity. Additionally, sleep deprivation can lead to insulin resistance, which later develops into type 2 diabetes. So the location of our study is Khayelitsha, which is the largest township in the Western Cape, with an estimated population of around 2.4 million people. It is located 30 kilometers southeast of Cape Town CBD and is highlighted here, as you can see in blue. It faces a variety of socio-economic challenges, including high levels of unemployment, poverty, low levels of infrastructure and service delivery, crime, substance abuse, and the prevalence of gang violence. Additionally, there are particularly high rates of non-communicable diseases like stroke, hypertension, and diabetes mellitus. The aim of my study was to explore and quantify the effects of the thermal environment on sleep patterns in the Khayelitsha cohort. And my hypothesis was that high temperatures will result in disrupted sleep patterns and reduced sleep quality. Examining how high ambient temperatures affect sleep patterns in Khayelitsha will show the extent of rising temperatures on sleep, with a focus being the low-income setting. My methods involve three main steps, the first one being data acquisition. So this involves a secondary study, acquiring the data from the existing METS study, or modeling the epidemiologic transition study, which is Laura's study, as she mentioned. And this looked at 2,500 adults of African descent from Ghana, Jamaica, Seychelles, South Africa, and the USA. However, this study just looks at the South African cohort in Khayelitsha. Then temperature data was acquired from the South African weather station, which is within 10 kilometers of Khayelitsha. And this included hourly readings of temperature, as well as hourly humidity, wind speed, and precipitation. The next step was data preparation. So sleep and participant characteristics underwent quality control, which resulted in a total of 195 participants with approximately 1,400 nights of data spread from November 2020 to November 2021. And then finally, statistical analysis was underwent, and this included bivariate analysis using Stata, then multivariate analysis adjusting for covariates using Stata, and then finally data visualization using RStudio. So how exactly is the sleep data acquired? Well, objective sleep is acquired using wrist actigraphy for each participant over approximately 7 days. And then the sleep data is collected in 1-minute epochs, providing very high definition data. Sleep data is scored using the criteria of Patel et al., and this generates a number of different sleep quality variables. The 8 main sleep quality variables, which we looked at in the analysis, included sleep onset latency, sleep efficiency, wake after sleep onset or WASO, percent wake, the average length of each wake bout, sleep duration, number of wake bouts, and then total sleep time. The main focus, however, for this study, which we're going to talk about today, is sleep efficiency, which is the percentage of time spent asleep between sleep onset and sleep offset, and percentage wake, which is the proportion of minutes the subject was awake during their total time in bed. So after acquiring the data and preparing it, this is a summary of the participant characteristics. So we have medium, interquartile range, minimum and maximum given for continuous data, while frequency and percent are shown for categorical data. These participant characteristics provide a range of information from basic characteristics, health measurements, and lifestyle. Next up, we have housing environment of each participant with frequency and percent shown. Most notably, we see house density, roof material, and wall material. And then both participant characteristics in the previous slide and housing environments seen here are included as covariates in the statistical analysis. Here we have the nighttime minimum, average, and maximum temperatures for the corresponding dates from November 2020 to November 2021. Highlighted in gray is accepted range of comfortable sleeping temperature from 15.5 to 19 degrees Celsius or 59.9 to 66.2 degrees Fahrenheit. So the multivariate statistical analysis, adjusting for all the covariates, show the nighttime maximum and minimum temperature with the sleep variables. While humidity, wind speed, and precipitation were also examined, they didn't have sufficient evidence showing their effect on sleep, so I haven't included them here. Highlighted in yellow, we see the statistically significant results, which have a p-value of less than 0.05. And these show when the temperature reliably affects the different sleep variables. Increasing nighttime and nighttime maximum and minimum temperature cause a decrease in sleep efficiency, an increase in percent wake, an increase in the average length of wake bouts, a decrease in sleep duration, and a decrease in total sleep time. If we focus just on efficiency and percent wake, it is evident that for efficiency and nighttime maximum temperature, we see that the coefficient is 0.22. So for every degree increase in temperature per Celsius, we see a 0.22% decrease in efficiency of sleep. And similarly for percent wake and nighttime maximum temperature, the coefficient is 0.19. So for every degree Celsius increase in nighttime maximum temperature, we predict a 0.19% increase in percent wake. So having this data not only allows us to look at how temperature affects sleep, it also allows us to look into and investigate other interesting relationships between the data. Firstly, this is a simple regression graph of nighttime maximum versus participants' percent wake for the night. However, we can further divide that data into participant characteristics, for example, biological sex. Females, as seen in red, have a higher percent wake than males in blue. And then here for diabetes, we see those with diabetes in blue have a lower percent wake than those without diabetes. And then we see here for employment, those who are employed have a lower percent wake than those who are unemployed. And so while this isn't directly in the scope of my research, it shows what is possible with the data. So in conclusion, increasing nighttime maximum and minimum temperatures have a significant impact on efficiency and sleep quality. Increasing nighttime maximum and minimum temperature cause a decrease in sleep efficiency, an increase in the amount of time spent awake, and a decrease in total minutes spent asleep. The future scope of this research involves applying these study methods into other cohorts around the world from the MET study, including Ghana, Seychelles, USA, and Jamaica, giving higher resolution of data analysis across a wider range of participants and environmental conditions. It is evidence the importance of discovering the relationship between temperature and sleep, not just for the sake of improving sleep efficiency, but also in the expectation of increased global temperature in the years to come. Understanding these relationships will allow us to be better prepared for the future. Thank you so much.
Thank you so much, Alice. That was phenomenal. Of course, I'm a little bit biased. The data comes from our modeling the epidemiologic transition study that we've been doing at Loyola since 2008 with the team at the Parkinson School of Health Sciences and Public Health. And so what we got was just an amazing, very quick introduction, start from Julianne, giving us the gaps in the literature, to Amber really talking about extreme water events, and then to Alice really drilling down to show how we can use objectively collected data to really understand these problems. And now I'm actually going to do a very quick summary and introduce you to a study that we actually are just getting up and running in two countries in sub-Saharan Africa, in South Africa and in Ghana, and to show you how we can use that data. So I am going to share my screen and just take 5 minutes to share our new study with you. And it is titled Heat Adaptation Benefits for Vulnerable Groups in Africa. And the team came together from our ongoing work through Loyola University and the MET study. So we used two of the MET sites. So this project is specifically to co-develop and implement within 4 communities, 2 communities in South Africa and 2 communities in Ghana, socially desirable, affordable and scalable heat adaptations into intersecting communities in sub-Saharan Africa. So our focus is on low income and informal settlements. And then we want to also look at people engaged in manual labor, since they make up over 50% of the population in sub-Saharan Africa. Alice already showed you some pictures, but this is from Khayelitsha in Cape Town, South Africa. This is Thohoyandou, just outside of Johannesburg in South Africa. This is the village where I'm doing my work from right now. This is in Kwantakesi in Ghana. And then this is Gamashi, which is a township as part of the Greater Accra in Ghana metropole. And we're going to actually go in and do objective health and social outcome measurements in our work. And then we're actually going to implement heat adaptations in the homes and for people who do manual labor. And we're going to quantify how those heat adaptations may improve people's responses, their human physiologic response, as well as mental health, socio-economic and environmental measures. And through this project, we also hope to grow the pipeline of African researchers working at the intersection of climate and public health. What is really important for the study is that a lot of studies have relied on self-report, and a major component of our work is that we're going to objectively capture people's health. So we're going to look at dehydration status using standardized urinalysis machines. This is a core body temperature monitor, which measures the person's core body temperature. Alice showed you what we can do with the sleep watches or the actigraphy. This is also a physical activity monitor. We standardize body weight, blood pressure, and we look at fasted blood sugar to look at diabetes risk and measure body fat. On the climate side of things, we installing at all of our sites a cellular weather station that is solar powered. It has sensors that are linked to both indoor and outdoor temperatures, depending on where the device is. It measures humidity, barometric pressure, and part of this is that there are SMS alerts, which is part of the early warning systems that Amber was alluding to. And all of this is stored on a micro SD card, which talks to cell phone technologies. We're also installing in our communities temperature and humidity data loggers so that we can actually capture the temperature that people experience in their homes. This is actually from today. This is in Nkontekesi, where we just handed over our automatic weather station to the chief, Nanaboa Chiyam. And this is our Met team in Ghana as we did the handover of the automatic weather station and getting it ready for the startup of our study. And this study is funded by the Wellcome Trust, who have now developed this Wellcome Trust heat adaptation cohort. And so we all met in Mombasa in September. And all the funded groups were there, and whether it was introduction, workshopping, support mechanisms, looking at the theory of change, how do we engage communities effectively, and how do we ensure that we are on the ground doing capacity building initiatives. And just to give you an idea of the other studies that were funded, there around the world, there are 9 studies. And in Tanzania, they're looking at can trees reduce heat stress in agricultural workers. In Mexico, Burkina Faso, India, and Nauru just off the New Zealand, they are looking at whether cool roofs are an effective solution for reducing heat exposure in people living in vulnerable housing. Another study out of South Africa and Zimbabwe is looking at how can health risks of extreme heat on pregnant women and newborns be reduced. In Mexico, how can heat health action plans help manage the effects of heat in rural Mexico? In Pakistan, they're looking at what are the most effective heat health interventions for vulnerable urban and rural populations. In another study out of India, they're actually looking at the economic and health impact of heat adaptation. In Malaysia, there's a study that's how can simple behavioral and structural changes protect people from extreme heat in Southeast Asia. And finally, the study out of Kenya is looking at can simple home modifications reduce the health effects of heat in Kenya. So these are some of the partners that we are partnering with for our own study. It's important to note that SDI put them at the center. Slum Dwellers International is our community partner who will be building this project on the ground from a community perspective. One of the important aspects is workshopping the interventions with the communities to make sure that they will be acceptable to the people who live in those communities. It is no good as scientists if we go in and tell people what to do as opposed to seeing what people actually want on the ground. And so at that, I am going to open up the panel now for any questions that might come. I'm happy to entertain a variety of questions and would love to know if there are any questions from our online panel. And please use the chat at the bottom of your screen. You will see the chat feature, and it is you can actually put your questions into the chat box, and we can take those questions as they come up. While we're waiting for the question, I just want to take the opportunity again to thank everybody for their time. As we have seen, this is a real problem that needs creative solutions that will come at the problem from many different angles, and it is certainly very transdisciplinary. And certainly in our Havia study, we are partnered with not just the SDI, but we are partnered with community partners, climate scientists, anthropologists, and as well as epidemiologists like myself and endocrinologists like Julianne. And we obviously have many students that have joined the project that will be working with the data. All right, I am not seeing any questions, so I'm actually going to take the liberty to start off with the questions. And Amber, I wanted to start with you because I know that your work has overlapped a lot with Julianne, and that you had actually looked at a lot of gaps in the literature focusing on vulnerable populations. And I wondered if you could just share some of your experience with that.
Sure. I think, I mean, from the perspective of our kind of overview process, what we recognize is that so initially, obviously, we thought, okay, let's see if we can do any meta-analysis. Can we bring any studies together? And because of the different ways in which extreme weather events as variables are understood, so the way they're defined, that became really difficult. So I think one of the gaps would be a standardization or a set of understandings or shared definitions around what constitutes, for example, a heat wave, and I know there are climatic ones for this, but then maybe in health sciences, we need to align with a particular way of thinking.
That's true, and especially because the only way to tackle this problem is a transdisciplinary approach. All right, we have a question from the audience. Please advise what community engagement model is applied in the programs and what tools used for co-creation strategies. So I think that you are referring to the Happier study that I just presented, and we are going to use co-production workshops. And so the participants from 2 of the sites in our project are already ongoing longitudinal cohorts with over 10 years of working together. And then we have new cohorts. But what we have engaged is with Slum Dwellers International to be our partner as we go in and do these co-production workshops. And we will do focus groups as well as bring other heat adaptation models that have been used in other programs, and then see how people respond to that. One of the big focuses that we've needed to that we've identified is that because these are low income communities and vulnerable communities that we're working in, the solutions need to be affordable for the communities that are on the ground. And so it's, and in addition, many of these communities don't have electricity. It's very easy to go and say, oh, just install an air conditioner. And then many people want air conditioners, but it is certainly not possible when we have very little electricity, continuous electricity in many of these populations. So SDI is going in with us, and we are doing these large co-production workshops to come up with solutions that will work for the community. All right, I don't see any other questions, so I am then going to ask Julianne. Julianne, so you really focused on type 2 diabetes, and you did not find anything, really a lot of data around gestational diabetes, or what? So how do you feel that this literature may be improved upon?
Yeah, with our search terms, we search for gestational type 1, type 2, and pediatric, but didn't find as many gestational diabetes articles as with the other types of diabetes. I think one challenge that comes with that is that gestational diabetes is limited by just a couple of months. So there's just a much shorter time frame for studies to be done. But I guess that's specifically focusing on the areas in the world where there has been more changes in temperature or more exposure to natural disasters, where we can understand where there's a higher impact on climate change, on gestational diabetes would be the best place to start getting that data from, so that we can better understand the impact of climate change on gestational diabetes.
Thank you so much. And in 30 seconds, Alice, if you could identify the gaps and how you would like to move this research forward, if you were given unlimited funds, I know you're just embarking on your career, where would you go in 30 seconds?
Sure, thanks, Laura. Yeah, so there are many research gaps here, and especially in the global south, which we are trying to grow that literature. That's what we're doing. If I had unlimited funds, I would probably go towards what you're doing with the Happier project, getting internal temperature and humidity readings, which are really important for sleep. I mean, there are a lot of other factors, well, not a lot, but things like sound disturbances and light also plays a role. And so kind of pairing objective and subjective to get a more holistic reading and understanding, I think would be the next step. And then obviously expanding it to other places and getting a bigger range. As I mentioned with the METS project, there are other areas of research and other locations that we can apply these methods to. And so just expanding and growing upon that would be great.
Brilliant. Well, Alice, thank you so much. We wish you well on your new academic career, having just graduated with your honors. Congratulations. And Julianne, good luck with your new grant looking at type 2 diabetes. And Amber, of course, I always enjoy working with you and look forward to working with you some more. Thank you for your time, everybody. I hope you've enjoyed our webinar and keep looking at the research.